Next, we'll have case discussions. Because of the time, we'll probably do just one quick case. And I would like to request the panelists, Dr. George, Dr. Stricker, Dr. Yu, Dr. Shah, and Dr. Frye to come over to the stage. And we can quickly review one of the cases. So the reason I'm presenting this case, a lot of time when we do focal therapy, even when we have recurrence, we are able to salvage either by repeat ablation or repeat prostatectomy. And I used to believe that in all these patients, we're not compromising oncological outcome and that we're not closing the window of cure. But this is a case which kind of I was really bummed about. And we'll go through that case and see if I could have done something different. So this is a 67-year-old Hispanic male. I saw him earlier in my experience, the first couple of years when I was doing, I started focal program at Cincinnati. Nothing concerning on his preoperative workup. Had Pirates 4 lesion, 1.2 centimeter, right mid PZ, straightforward. Crowd case. We used to use endorectal coil back then, so there's a little bit of artifact. DWI is not perfect, but ADC is showing the lesion corresponding to T2 hypointensity. He underwent uneventful focal cryoablation and with fusion guided with 1 centimeter margin. At least I planned for a 1 centimeter margin. Post-operatively, he got an MRI and protocol biopsy at around 6 to 9 months, which was negative for any residual cancer. At 24 months, he got repeat MRI. His PSA dropped down to 2 point something. It was slowly rising, but had not failed biochemically by Phoenix criteria. He got a repeat MRI 24 months. It was still negative, so he did not get another biopsy. Until year 4, his PSA had now risen to 5.7, so it failed biochemically. We got a repeat MRI, and we ended up doing the biopsy. He had recurrence in the right base, as you can see on T2, ADC, DWI, contrast enhancement, almost into the bladder. I biopsied it. It came back as, just that spot came back as grade group 4 millimeter. He was 4+3 before the cryo, and now it was 4+4. And this was a residual, probably cancer at the margin, which grew slowly over the 4 years to finally manifest on imaging. We had detailed discussions, and I knew repeat focal is probably not a great idea in this location. So I ended up doing robotic prostatectomy. And actually, this was kind of nubbin of cancer in the bladder when I opened the bladder. And I excised everything. It was a positive margin, this gentleman. His PSA went down to undetectable, but stayed detectable for only 6 months and slowly starting creeping up. And now he had failed biochemically after prostatectomy. So I guess I gave the answers what I did. However, the question for the panelists, is this a scenario where focal therapy failed, and would a radical treatment upfront provided this gentleman cure? Because he had not failed distantly, he failed locally. Or should I have done something different?
I'm not convinced this is like a margin failure based on the images. I feel like this is de novo disease, especially because it wasn't detected on subsequent imaging as well. And so the answer to your immediate question is that I'm not convinced that radical therapy would have provided well, I guess it would have provided cure up front potentially, but not for the reason that focal failed. And I think that's part of the counseling that is integrated within focal therapy, that you can have out-of-field failures, and that's part of the decision-making process. That's the trade-off, right? Prof. Stricker, like I said, there's a trade-off. And I think that's part of the trade-off and I'm extraordinarily transparent with patients. this is not a treatment that you need to sell with patients, as you can see, as the result of this randomized trial. In fact, you have to convince patients they are not a candidate for focal treatments, has been my experience.
How depressing. I mean, this is what we all don't want. But what's really interesting is, and we've all got these patients, what's really interesting is I would ask you, does that patient have regret? And I bet he doesn't.
He doesn't.
And it's really interesting because if you take the regret on the whole gland therapy, and who's the regret on the whole gland therapy? It's patients who recur after whole gland therapy or patients who get incontinence or severe impotence after whole gland therapy. And those people have enormous regret. Now, as focal therapists, we are meticulous about informing people about this horrible scenario, which is exactly what we're trying to avoid. But do they have regret? The answer is no, because they've been walked through the whole program, they've been counselled with the whole program. Maybe you would have cured them, but they knew they made a decision at the beginning because of appropriate informed consent. So I think the question we have to ask as clinicians is we have to avoid regret in our patients, not this scenario.
Okay, thank you. Would anyone offer him repeat ablation at that setting?
That's what I was going to say was the answer is no. I think it's just too basal, really.
Yeah, too
But
basal.
your original decision was correct. Probably would have used a different energy, but it doesn't really matter. It is away from, it's far enough away from the kind of peripheral margin for you to use cryo as well. What was your pathology at prostatectomy, and have you done a PET scan? I'm just trying to see why there's some patients we discussed that just seem to have a bad phenotype.
When he failed, PSMA was still not approved in US, so he got conventional imaging, CT and bone scan, which were negative. Now he got PET scan, it was still negative when PSA of 0.2.
Okay, fine. So he's going to have prostate and pelvis, or just?
So he'll have radiation, salvage radiation in that setting. Okay, thank you.
Hey, Abhi, just for consideration, in retrospect now, would you favor radiation over salvage prostatectomy, just given the location of recurrence high up in the bladder neck there?
I didn't make a decision for him. I of course wanted him to get radiation also, this was one of my first salvage prostatectomy and I was not super thrilled about doing it considering the location and knew there was a higher chance of positive margin, but the patient chose prostatectomy, this is what he wanted.
Can I ask the experience with radical prostatectomy post-ablation, and certainly what was your experience in this case, Abhi, and for others?
The surgery
who have done
itself was not challenging at all. I've done several since then, and even after HIFU, the surgery is not that challenging. Like we see challenging prostatectomies all the time for various reasons, infections, large prostate. So it was like a little bit not completely like a treatment knife kind of surgery, but it was not, I would not consider it challenging by any means.
And I would say in my own anecdotal experience, again, I've done a few of these now, not a huge amount. It's deceivingly not challenging. And you think you can get away with a lot more than you actually do. Specifically in that positive surgical margins, you see extracapsular extension that is not identified on imaging, bladder neck margins that can be positive. So now on the ipsilateral side of prior ablation, I will go very wide, even if, and I will not attempt any sort of nerve preservation, even if intraoperatively appears it's like that. And I don't do bladder neck sparing. Of course, it'll depend on where the location of the recurrence is, but I typically will not do bladder neck sparing, and I'll just reconstruct the bladder neck.
I think we all need to be a bit careful because Senthil Nathan and Vip Patel recently put a publication out in Robotic Surgery on the biggest series ever of salvage surgery. And they put it out as 300 patients, and they put it out as how difficult salvage surgery is and how shocking the functional results are. But they compared whole gland ablation to partial gland ablation. Yet what was missing in this particular review, which came out about 3 weeks ago, was one, the delay, who got what? They had radiotherapy cases in it. They had whole gland HIFU cases in it. And what was interesting was that the comments from the surgeons was that how difficult the contralateral side was. Yet that is not my experience. In my experience, as with Abhi and with Avi, it's not difficult surgery. Yes, it's difficult at the spot where you've done the ablation, and judgment is really difficult at that point, but it's not difficult. So I would recommend that when you read the paper by Senthil and by Vip, that this is a historical post-radiation and post really aggressive treatment paradigm. So I don't think it's comparable, and they use that as an argument against focal therapy.
We recently did a systematic review for all studies, salvage prostatectomy after focal ablation, not whole gland. And a lot of the focal studies which were included and got prostatectomy, they were probably older focals where it was more a template ablations, hemiablations, and hockey stick. We demonstrated, of course, the survivals were similar across all cohorts, but we did demonstrate there was definitely slight impairment of potency and continence rates for salvage prostatectomy after focal failure compared to primary prostatectomy. And I think that I have definitely incorporated in my counseling. Even though the surgery is not challenging, patients are definitely incontinent more often, and they're impotent more often after prostatectomy than if you were to offer them primary prostatectomy. So that has also made me treat them more aggressively the first time itself, because I know when I do salvage, I may be able to give them good oncological outcome, but I may not be able to maintain their functional outcome to the same extent.
I just wouldn't beat yourself about this. This is a standard case. It happens. You're going to get failures. I mean, think about how hard it is to salvage radiotherapy. 1 in 4 will get biochemical failure by 10 years. Should we stop doing radiotherapy on anyone based on that? The answer is no.
No, I agree.
Patients need it. So I think this is a standard pathway for a difficult patient.
Agree. Thank you. So we'll quickly do one more case, and I brought this case. Majority of our failures, so we advocate to do a protocol biopsy even when the MRI is negative, even when the PS is low, because we see rare failures in that setting, and this data from UCL. But what we realized anecdotally that when these patients failed, and I went back and sat with my radiologist to review the images, which were initially read MR negative, there's always something tiny, they can see it. I think the concern is low a lot of times, so they don't read it, or it's been read by somebody who's not super experienced. But you can always find almost something there. Rarely it's completely negative. So this gentleman, 71-year-old male engineer, had a lot of questions, had multiple long visits before he chose to get focal therapy, and he said he wanted NanoKnife. So he had IRE of this area, treatment went uncomplicated. He got his catheter removed in 1 week, had a little bit of gross hematuria. His PSA dropped down to really low number, 2.5-ish. And at 6 months, we got an MRI, which showed urethral diverticulum/cavity, red negative. Did a protocol biopsy on him, Gleason 4+3, grade group 3, largest score 4 millimeter. So same disease, residual, we didn't find it. I'm pretty sure if we had waited long enough, MRI would be positive, but it was MR invisible disease in that area. What would you do in this setting? He's 71, otherwise healthy.
I just ask, what do you consider a huge drop in the PSA? What do you counsel men? So it went from 6.1 to 2.5. Like, what do you counsel men is like an expected decrease in
I
PSA
tell them
usually?
at least 50% decline, but every time there's around 75% decline, I kind of reassures them that this is a probably good sign, you're less likely to have residual disease.
I just had a question about your repeat biopsy and your approach. Maybe you can comment on that. When you have a cavity, you obviously can't do any in-field biopsy. Do you biopsy around the cavity?
Yeah, I biopsy around the cavity, and I also still get 12 cores on all patients. So he failed in the right apical area.
In that case, how do you label your 12 cores? Because, you know, the zone is different. Like, how do you label the contours of, I guess, the cavity?
I think the zone definitely gets shrunken in the area which gets treated. So basically, you end up, if you do TR biopsy, I think this gentleman had TR biopsy. So he got 6 from right-sided, and we just labeled base mid-apex.
And just to be clear, the only positive biopsy was at the right apex, and the ablation was at the right mid.
Right mid to apex was the ablation. So he had positive systematic core at right apex, but the ablation core was also positive. The peri-ablation core, which I got through the cavity, around the cavity area, just randomly. It's difficult to determine where exactly the tumor was, right? So I biopsied a couple of spots in that area around the cavity, through the cavity, and one of them came back positive. So he definitely failed, and this is in-field failure.
It's a tough one, isn't it? How you treat this? Because if ignore your imaging.
And actually, I don't have the sagittal view. His now tumor has, like, the prostate has shrunken asymmetrically, and like there's just like the IRA does such a great shrinkage of the prostate. Like that side is really, really small now.
You'd want to say all of those options are completely reasonable, including redo-ablation. What energy, it depends on how worried you are with that diverticulum and probably what it looks like on an ultrasound scan as well, because that would impact what energy you use and how you treat it, and might make you choose a more radical treatment over a repeat ablation as well. I don't know what anyone else thinks about that.
Dr. Stricker, would you do repeat IRA here?
I have in the identical setting. I would definitely do a PSMA PET scan before I do anything there, and I do a repeat. And that MRI that you've got there, I don't know if that's a diverticulum or a cyst. If it's a diverticulum, then the PSMA PET scan is going to be a false positive in that area, which is just a warning. I mean, it's going to be a long conversation. How old is he? He's 70?
71, but healthy.
Yeah.
Would you use Axumin, which may have less, urinary excretion and have better like local evaluation, like flucyclovine?
Sorry, I didn't catch it.
Flucyclovine, which may not have that concern for a false positive. I know it's not now with PSMA PET, we're typically using that more, but flucyclovine may be an option to assess whether, that local area as well and distant as well.
Look, I've just been burnt badly with a false positive in a second opinion. A person who came who had been dished up to me for a radical prostatectomy with a very high PET scan positivity after a focal therapy. And thank God I did the MRI, which showed that it was a diverticulum there, and then repeated the biopsies, and all the biopsies were negative and did not take his prostate out. So my bias would be, we did a study, a New South Wales registry and Victorian registry of the incontinence rate of this particular man who's 70-ish, and he has a 1 in 3 chance of wearing pads at that age, and a 8% chance of wearing greater than 2 pads. So I think I would probably have a slight bias towards doing a repeat ablation.
Question for Dr. Stricker. The fact that you have this cavity that is probably either fluid-filled or urine-filled, how does that change the conductivity and your needle placement?
Yeah, so that fluid, presumably, that's why I was asking whether it's cystic or whether it's not, because is it electrolyte rich or is it electrolyte poor? And I don't think you can put a needle into it and suck it out, because it's not going to work. So I think my experience is when you've got something that doesn't conduct electricity, it ablates everything around it. So I would probably circumnavigate that area and just ablate, and you know that IRE is always going to give you a wider ablation anyway. And how it actually treats that cavity, whether the electricity would go through it or not, would depend on whether it's electrolyte rich or not. But I know that it's going to ablate the area around it. So I'd probably have a bias towards ablating it.
Abhi, I know my opinion would be that I think all those options are reasonable. You know, one thing that I hesitate on any sort of repeat ablation in him is the lack of any MRI visible area to really ensure that I'm treating what I really want to be treating. You know, so in that regard, I think I would favor a more definitive salvage.
That's good. Yeah, he was an engineer. We had a long discussion with him for hours and hours. He wanted to repeat nano knife, and I was not willing to do that because I was worried maybe he has those concentric failures at the capsule edge, and if it's just like that thin failure, would I be able to get it again with IRE? So ultimately, we just did HIFU, very aggressive treatment in that area. And I had previously treated distal apical tumor with HIFU and got lucky, and we treated it. He had Foley for uncomfortably long period of time, 4 weeks. We actually had to give him steroid pack, which I had never given before. And he urinated after that, and his PSA dropped below 0.5. He's happy, like he's not incontinent, he's being okay, no issues.
Again, SBC, I mentioned this before, it's probably underutilized sometimes, and this sort of patient might have been useful rather than having a prolonged catheter for.
Yeah, well, that was first time, like he was not able to pee for first 3 weeks, and so I called someone and they recommended steroid pack, and that's what I did, and it worked really well. Okay, so I guess we'd probably not go through other cases since we're already running behind time. Thank you for our panelists to join us for this case discussions, and